Going? Here we go. All right. Well, welcome everyone to our first Echo Dementia session of 2025. I'm going to go ahead and share my screen and want to express my appreciation for you all taking time out of your busy days, lives, clinics, all the other things you're doing to learn a little bit as part of our Echo community. So here we are, January 10th, 2025. As is our custom, we'll do just a few very brief opening notes and reminders. If we have time, maybe we'll do some introductions. I think we've got some new faces to me anyway here. And then we have the great good fortune of having our own Teresa Keene here to talk about Alzheimer's disease research in our ADRC here at the University of Washington, which is one of the oldest and largest in the country in our clinical trials. We do not have a case, but we have a lot of opportunities to have a very dynamic discussion around the interface between research and clinical care, and your kind of experiences being referrers to research or being asked about it. Even within our own clinic here, we have a high degree of heterogeneity in terms of comfort talking about research or referring folks to it. So this is a great opportunity to chat about that. Let's see here. So a couple of reminders. If you are able to, please do feel free to rename yourself with your first name, last name, clinic if possible. It's a lot to type, or you can put it in the chat. We have mostly mastered muting when we're not speaking. I'm still working on saying my name when I unmute. I didn't even do it today, but I'm Chris Rhodes. I'm a neuropsychologist here at UW and co-lead of this wonderful program with my colleague and friend, Dr. Nancy Eisenberg. If you're able to, your video on is always fantastic as we build our community here. And it's rare these days, but if there is more than one of you in your location, making sure that their names are in the chat too, just so we keep track of who's here for CME and other purposes, much appreciated. Speaking of which, for all of our UW faculty, staff, students, this is the process for registering for and obtaining CME. It's a pretty painless process, and I believe CME is now free at the University of Washington for UW faculty. If that's not true, we'll edit that out later on. And for everyone else, it is free. That's part of our benefit of being funded by the state of Washington, and we will hope that funding continues given our current financial status here in the state of Washington. But Sammy and our rest of our team here will keep track of that. Want to bring your attention to some other resources for your clinical practice, including the UW Echo Geriatrics, which is in between our sessions and a fantastic resource for larger geriatric issues. There's a couple of other echoes there. And then the consultation options here. So there's a few here. And we should probably throw the stroke phone on there too, which is a great whammy resource. Psychiatry grand rounds, neurology grand rounds, embarrassment of riches in terms of educational opportunities here at the University of Washington and our partner organizations. Want to also remind you about the upcoming Dementia Innovation Summit, which is a chance to showcase some of the work that has happened with the Dementia Action Collaborative and partner organizations. And Project Echo stems from the DAC related programs. The early bird discount has passed, but there's the registration info that's going to be on March 7th at Valley Medical Center. And lots of primary care oriented topics, clinically oriented as well. Cases, oh my goodness, we're going to double down in 2025 on cases, whether it's ideally from our community or perhaps our hub team, but we love your cases. No case is too small or too complex. We always learn something from them, and it is, in my opinion, some of the best part of the learning. So, and then, we don't have a case necessarily, but in our clinically oriented discussion or vignettes, just being sure to protect PHI. We have the opportunity to go back and edit things out. We have done that in the past when needed, and then post all of our sessions too. And of course, part of the reason that this program looks the way that it does these days is based on the feedback that we received from you in our post-session surveys. I know they're painful sometimes to get an email and click through all these things, but they really are so important to help us make this better for the community. ask you to keep an eye out for that. We are accredited for CME. Our presenter, our committee have no disclosures. Anytime there is a disclosure, there's a pretty strict mitigation process there at the UW. Here's our hub team. You know us already, I think. And this continues to amaze me, just where you all are and just the diversity of regions in our state and expertise and just the heterogeneity in the communities that you all serve. So really fantastic to see so many places represented and so many systems also. All right, so I'm going to stop there and introduce Teresa Keene, with whom I have had the pleasure of working for the last 5 years, hard to believe. Teresa is one of our research coordinators at the Alzheimer's Disease Research Center, and she is the only research coordinator that is actually embedded in our clinic. So she is in the provider workroom when patients and families who are in our clinic are interested in research. Providers will come out, Teresa will go in, and so it has a real kind of a unique perspective also in terms of interfacing with more people than would actually enroll necessarily in research. But my absolute pleasure to have her here, and I will turn it over to you, Teresa.
Thank you, Dr. Rhodes and Samantha and the rest of the ECHO team for having me. It's my pleasure to join today. I'm going to go ahead and share my screen. All right, can you see that all right?
That looks great.
Wonderful, thank you. And just before I get started, I have some slides prepared today. The focus will be general research concepts as they pertain to UW Alzheimer's Disease Research Center, and highlighting a couple of clinical trials and studies that we have going on currently that may be of interest to your patients and community members, as well as potentially yourselves. And then at the end, if there's discussion, I'm happy to take questions. And along the way as well, if you have them, I'll do my best to keep an eye on that chat, but feel free to call out if you have something. Well, all right. So I am, as Dr. Rhodes mentioned, a research coordinator at the Alzheimer's Disease Research Center at the University of Washington. And I'm going to tell you a little bit about studies and trials today. The learning objectives for today, I'm just going to move this out real quick so it's out of the way. Learning objectives for today are to introduce our research center's overall structure, mission, and primary aims, as well as give some examples of currently enrolling clinical trials and studies and some nitty-gritty details about those studies in case you're interested, as well as some general information about how to refer patients to our center to become involved with research. And last but not least, there will also be some information about frequently asked questions. And these are questions that it's a list that I've compiled based on my experience as a coordinator working with participants in the Alzheimer's disease and related dementia realm. But there are also some questions that have been influenced by other staff, faculty, and experiences. So just a list of those types of questions. To start, just a little overview of who we are. So the UW Medicine Memory and Brain Wellness Center is the umbrella organization under which the University of Washington Alzheimer's Disease Research Center, or ADRC, falls and is housed. In addition to our research center, the UW Medicine Memory and Brain Wellness Center is also home to a specialty clinic where many medical providers, including some in the audience today, work. And that clinic, I am also embedded as a research coordinator in discussing research with potential participants who are also patients. We're going to focus less on the clinic today, more on research. And then the third entity under that, grossly under that umbrella organization is, of course, the Memory Hub Dementia Friendly Community, where Project ECHO is hosted from. The research center has a couple of different types of research, probably more than the two listed here, but this is a very simple breakdown of how we classify different types of research at our center. There is definitely overlap between these two categories, but for simplicity's sake, research tends to be lumped at our center into the categories of clinical trials and observational research, and we'll get into that and some specific examples in a bit. And one of the primary mechanisms or pathways to becoming involved with research at our center is through what's known as our research registry. And a lot of organizations and institutions and clinics even have their own versions of this type of entity, which is a way for people to access research. So I'll tell you a little bit more about those things as well, but this is just an overall breakdown. Up in the upper right, this is a map of the current NIA-funded designated ADRCs across the country. We're actually one of about 37. The darker blue are those that are officially NIA designated, and then lighter blue are those which are exploratory, perhaps on their way to becoming officially NIA designated, but not there yet. And ours here at University of Washington is the only one in the state of Washington, and the next closest to us is Oregon down south. And as you can see, there's a bit of a gap in the middle states, and we get participants at our center from near and far, all across the greater WWAMI region. So it's unique in that regard, but it is one of many. And it's also our aim to accumulate scientific knowledge and help create treatments and prevention for Alzheimer's disease, but also related dementias. And that's important to note. Even though our title literally has Alzheimer's disease in its name, we study more than just Alzheimer's here. And our center is open to the public. While we have a focus on neurodegenerative diseases and conditions impacting our memory and thinking, a lot of times studies are looking for people who don't carry those diagnoses. So that's important to know. We are currently also located at Harborview Medical Center. And we operate across all UW campuses, primarily here in Seattle, as well as the VA Beacon Hill. These graphics, I just thought I'd throw in. The one on the left, of course, is a breakdown of different types of dementias that are commonly seen that we often have research studies for. A couple of these I'm not going to talk about so much today because not all of the studies I'll talk about today are touching all of these different conditions, but each teardrop, of course, is represented through research or has been, if not will be in the future at our center, and Alzheimer's is among them. And then on the right, of course, is a breakdown of disease stage. A lot of times this is how ADRD research is categorized and broken up and impacts eligibility criteria, which could be helpful just as you interact with patients, having a general sense of what stage they're at. It's preclinical versus mild cognitive impairment versus a different dementia stage. There are going to be different research studies available a lot of times based on disease stage. And then another graphic just talking about how we break down clinical research at our center. Again, as I mentioned before, there's a lot of crossover with this. And this, right now, I'll kind of focus more on clinical trials as an evaluation of a treatment or of a drug or device, although it can also be an intervention, a lifestyle change, a support group, something of that nature. But I will primarily be focusing on drugs or devices, and also focusing mostly on what impacts individuals at the early stage Alzheimer's, early to moderate stage Alzheimer's stage. And then observational studies on the left, looking primarily, again, at longitudinal follow-up over time, touching base with people, gathering data over time on specific participants, and then comparing an aggregate. And also looking at risk and protective factors for Alzheimer's. And of course, down at the bottom, this is disease stages that are another way we categorize research. A question that comes up a lot among participants and what may be front of mind when when they're making that decision of whether or not to become involved is why participate? Why would I get involved? In my experience, a lot of people will get involved due to a sense of meaning and purpose. It's often from a place of altruism or hoping to impact and help future generations. And a lot of times people will also hope that there may be some benefit to themselves, which sometimes there is and sometimes there isn't. And as you can imagine, that really varies a lot on what's being studied, but we'll get into that. Can also be helpful to better a person's understanding about a disease and different treatment options. And in the cases of clinical trials especially, can provide access to novel treatment approaches that are, of course, still experimental and may have different risks or benefits associated. And this is a text-heavy slide, but I just thought I'd point out some of the common statements I hear, variations of the statements that I hear, and some responses that I would have to them. Regarding safety, and you can kind of scan through what these are, and I'm sure many of them you're familiar with as well. Terms like, you know, researchers want me to be a guinea pig. Maybe won't have the same level of respect for me as for an animal. That could be the kind of message that they're conveyed. If they're not particularly familiar with research, they may think of animal trials and or even past biomedical ethical transgressions, which our history is rife with, and people may not be familiar with what the current protocols and safety measures are that clinical research undergoes and what our kind of rigorous scientific process entails. So I have a lot of conversations with people about what is true and what to expect. Regarding safety, that's one of the primary concerns of both participants and researchers, is that a lot of the studies that happen at our center, they tend to be later stage, phase 2 and higher. And at that point, it's a lot of side effects have been studied, and a lot of medical monitoring is involved. And it's not universally true. We definitely have run earlier phase studies and have affiliates who are doing preclinical work or very early stage human trials, but the majority of research studies happening at the center have been phase 2 or phase 3 even and higher, which is of course larger patient population and working on dosage and such in larger groups. And then also regarding expenses, people often have questions about how much it will cost them to be involved in research. They're reminded of medical expenses and how costly it can be to go to the doctor. And one of the primary differences here that I like to distinguish with patients is more often than not, if it's something that the study needs and the study is conducting, it's something the study pays for. The rare exception here, well, the exception here would be if the study is working in tandem with a patient's medical provider and perhaps piggybacking on what medical tests are being run through their medical provider. And of course, the patient in that case would have all the test results and access to their data. They would also be paying for it, but they would be sharing that information with the research team, with the study, so that they can also access. So basically, if it's something that isn't already being ordered by the patient's medical provider for clinical purposes, then that's where it becomes a research designation. And these details are always outlined very, very closely in the study protocol. Patients are given as much time as they need and as much guidance as they need to walk through these documents, informing patients on everything from the study purpose to risks and benefits to compensation to travel details before they're ever even expected to enroll. And that's a part of the informed consent process. And last but not least, talking a little bit more about in-person participation. So, of course, our ADRC is based here in Seattle. And while we may conduct different study activities on different campuses, not everyone who's a patient is here in Seattle, or it's not always easy to get here. We like to mention in that case that while some studies can be completed partially or entirely via Zoom or telephone or even through a mail-in survey or something over email, most clinical trials, at least that I've observed here, do involve at least some level of in-person involvement in Seattle. And that is primarily the primary rule of thumb here that I've observed is the more medical monitoring is necessary, the more in-person involvement is necessary. So that can be a barrier for participants, particularly traveling from out of city or out of state. And a lot of times studies, depending on their budgets, you see it's more common a lot of times in the larger industry-sponsored pharmaceutical studies, for example, they may have larger budgets to be able to compensate things like hotel stays or travel reimbursement, but not always. A little bit of a clinical trials overview here. This is just a common image that I took from online of the different clinical trial stages, as I mentioned. Most of our studies are mid to later stage that we are conducting here that fall into that clinical trials category, although there have been earlier stage phase studies that have been conducted here. And we are actually going to go over at least one phase 2 study today, depending on time. So that, of course, it helps to determine the participant cohort size and also the overall aim of the research and what they're trying to get out of it. I should mention, every step of the way, especially once it hits human trials, is, a primary concern is safety, and most clinical trials in the US are regulated by the Food and Drug Administration. This next slide is I won't go into too much detail because many, if not all of you, are quite familiar with these procedures, but a couple of notes about this. Participants, in my experience, are often really curious about what they have to do, understandably, what is expected of them. A lot of times in ADRD research, there are going to be common procedures that people have to undergo or commonalities. I like to get a sense for people's comfort level for these different types of procedures. If I know if I know those procedures are involved in a study protocol. And these are some of those common procedures. Lumbar punctures come up a lot at least currently, in ADRD research, as well as brain MRIs and PET scans of all varieties, not just amyloid PET scans that are listed here, but other types as well, like tau PET and FDG PET. A lot of times people wonder if they can share these results with their providers. And that is a really valid question. Every study protocol is different when it comes to sharing of results back with participants. And it's common for studies to actually be a little prohibitive. They may not allow participants to have access to full results, unlike what they would experience going to the doctor's office. And that can be for a variety of reasons, proprietary concerns, or somehow impacting the data. Whenever I'm speaking to participants, and in the case of working in the clinic, providers as well, I'm trying to keep in mind which test results I can and cannot, the study can and cannot share with a participant, and what may be available for them to access later, because a lot of these results are desirable and would provide valuable feedback to a provider. What commonly happens is when studies can't provide full results, so for example, they can't provide a full disc for a brain imaging session, sometimes the medical provider overseeing, or the PI overseeing the study, they still may be able to share some basic information with a study participant, depending on the protocol, or an overall summary. And sometimes that's valuable for the patient to know about and for the patient to communicate back to their clinician or medical provider. So I always ask study staff running these studies to make it as clear as possible to participants which specific results they can share with their participants, and at what point in the study they get those results back, because that will also vary. Sometimes studies can't share results until every site conducting the study has completed A lot of these larger studies are multi-site and have to wait until someone is unblinded and know if they received the placebo versus the study drug. And also what results are being shared. So that's always a really good question patients can ask, and study team members can be sure to touch on in the informed consent process. And of course, if there are ever incidental findings, I've never seen a protocol that doesn't have the ethical obligation to share those incidental findings in some nature back with the participant. For example, if there's a brain scan and they find something, a mass or something on that image that they weren't looking for, but they just happened upon, that's something that most studies are ethically obligated to share. They may or may not be able to share it in the detail they would like, but it's something that they can do as much as they're able to do. Other common tests that I didn't mention here, but I'll just throw out, are blood tests. Everything from safety labs to ApoE genotyping to p-tau or amyloid levels, which are now becoming available through different blood tests, as well as cognitive testing, which is pretty much universal across these types of research studies. Everything from Montreal cognitive assessments to mini mental state exams to more extensive multi-hour neuropsychological tests being conducted for the research study. A lot of times these studies will also require a study partner. It's very important, particularly studies involving patients who may have some level of cognitive impairment. There may be a need for a collateral historian, and that is often a requirement for studies, and it can be a barrier, unfortunately, to participation. Right, and we'll jump into a couple of specific studies here. And full disclosure, I'm not a medical provider, nor am I the primary coordinator for any of these studies, but I am familiar with the protocols and have drawn a lot of this language directly from protocols and study documents, and members of the study team. So if you ever have any specific questions about, for example, drug mechanisms or really protocol level specific questions about these protocols, I'm more than happy to put you in touch with the study team. They'll be able to help answer those questions. So the first study I will highlight is a new one. It just started up at our site and is actually just about to start enrolling participants, and it is involving a medication called mevidalin. The sponsor organization is Eli Lilly, and our site PI is Dr. Michael Rosenblum, a neurologist, and a neurologist at the Memory and Brain Wellness Clinic, and also the director of our clinical trials program here at the UW-ADRC. I've summarized some basic information about the study on the left here, and I'll draw from that, but I think this branch of this study is actually phase 2. And there were studies run before it. There have been studies run before it, particularly in patients with diagnoses of dementia with Lewy bodies and Parkinson's disease. This phase of the study is going to be tested in patients with mild to moderate Alzheimer's disease. And it's exciting because it includes moderate stage disease. At our site, it's more common. I have found in recent years, it's more common to have clinical trials that are geared really towards the earlier, milder stages. But the fact that this one is inclusive of more mild stage impairment, I think is pretty nice to have that option. Mevidalin has been studied in patients living with Parkinson's and Lewy body. Again, now we're testing at Alzheimer's. And Alzheimer's, of course, part of that is defined by the presence of beta amyloid containing plaques and tau containing neurofibrillary tangles. And there have been, the prefrontal cortex is involved with working memory, attention, and executive function. Mevidalin is a D1R receptor agonist for dopamine. And dopamine in the medical PFC can modulate the short-term retention of information and other executive functions. So studies have shown that the administration of a D1R agonist can facilitate PFC-mediated working memory in animals and humans. That's why they're testing it. This phase is going to be looking for about 300 participants. I think it's an even breakdown between the three arms, which are going to be two different medication dose levels that get titrated up to the maximum dose listed here. The maximum dose of the first arm will be 25 milligrams. Administration route is an oral pill. The second group is maximum dose of 50 milligrams, and then the third, of course, is placebo. So 100 of each approximately. The age range is around 50 to 80 years old. And participants with a diagnosis of mild to moderate stage Alzheimer's disease, which for the purposes of this study, they have a cutoff of a MoCA score of around 6 to 18, which translates approximately to a mini mental state exam score of 13 to 24. Of note, this study does require, and this is quite common among ADRD clinical trials actually, if you're taking any psychiatric or antihypertension medications, something along that vein, it's very common for this type of study to require some level of stable dosing on any of those medications, if not outright exclude for those medications. This study doesn't exclude if someone's on those meds, but it does require a stable dose for at least 30 days. And we realize that people may be titrating. So again, final titration, stable dose for 30 days before they can qualify for screening. It does require a study partner, as I mentioned, and participants can't have a significant neurological condition other than Alzheimer's. I still recommend, even if someone has another diagnosis and is interested in the study, to check, because sometimes an exception can be made, and that they don't always specify very clearly in the protocol what counts as a significant neurological condition. So you can always check with the study team if you're not sure. Of note too, this is a medication that's been studied somewhat in the past, and it has been shown to have side effects. Some of those are severe. There's even been one mortality. The specifics of the mortality is the cause of death was unknown, but the study PI deemed that they couldn't rule out that it wasn't the medication. This was a patient with Parkinson's disease, and it was also at a higher dosage. That study was testing 75 milligrams. Of note, this study, the highest dosage is going to be 50 milligrams oral administration. There have also been some severe side effects that were noticed. And again, similarly, they just couldn't rule out it wasn't the drug causing it. Those included confusion and disorientation, some cardiovascular conditions, some inflammation and swelling, and constipation. The phase 2 trial, again, it's going to be capped at a smaller dosage and oral administration route. Minor effects that have been observed are nausea, dizziness, increased appetite, headache, actually increased energy and drowsiness, and then also some difficulty sleeping, heart palpitations, that type of thing. They also observed in animal trials that chimpanzees were demonstrating behavior that could indicate that the study may have some addictive qualities. The chimpanzees who were taking it did appear to act as if they wanted more when they stopped being administered medication. And again, that was actually at an intravenous administration route. So that is an important distinction. This will not be intravenous administration route. This will be oral administration. Return of results for this study will be minimal. However, one caveat is that the study does do its own p-tau testing. If a person doesn't already have p-tau on file, in order to qualify for the study, they have to have p-tau levels indicative of potential Alzheimer's pathology. So if a person screens onto the study, they can know that if the study did the p-tau test, they have levels indicative of Alzheimer's. And then compensation for this study. This is actually, it compensates a lot by study standards, up to $900 over the course of 12 visits, and it's prorated, I think, per visit. I think there is some reporting that happens, and the study team walks patients through this, but there's some reporting that has to happen on taxes once that amount exceeds $600. But the study team is very good about notifying patients when that happens. It also compensates up to $276 for meals, but it doesn't, and the study team is also working with the sponsor if any additional accommodations can be made, particularly hotel stays, and covering the cost of people's hotel stays when they're in town. The study coordinator's information is here at the bottom. I will make the disclaimer here and let that carry for the rest of the presentation that these study specifics are always subject to change. It is not uncommon for sponsors and researchers to tweak and alter the specifications of their study, particularly as the results roll in. So there's always the chance that this information may become obsolete or change over time. I always recommend getting in touch with the study team directly to see if those have changed. But that's the contact information for the study team here at the bottom. Oh, and I'm seeing a raised hand. I think it's Dr. Gaster. Should we answer questions now or at the end? Whatever's preferred. Go for it, Dr. Gaster. Hi.
Great. If you could go back one slide.
Yeah.
When I think of a MoCA score of 6 to 18, I think of that as like pretty more severe disease. And so I'm surprised that this is sort of in the mild to moderate Alzheimer's disease category.
Yeah. And I want to clarify, the MMSE score is what is specified in the protocol. So that 13 to 24 MMSE score is what's actually written in the protocol. The MoCA is an estimation, just based on studies that have shown how to make equivalencies between the two. So that it may not be an exact equivalency. And perhaps Dr. Rhodes or someone with neuropsychological expertise could weigh in on that. But the MMSE is more accurate because that's what's in the protocol.
Yeah, I would just add that, that crosswalk starts to get noisier as you get down to the lower levels. And, Brock, that a MMSE of 13 is not the same as a MoCA of 6, right? Those are two very different looking individuals. So it's a little bit of an artificial kind of a algorithm.
And I'm just like so not used to, I don't even really know what the MMSE sort of range is because I try to discourage myself and others from using it clinically. But I mean, so what is the MMSE sort of range?
13 would be the lower limit of the moderate range. Anything below that would be kind of the upper limit of the severe range. And 24 is kind of the cutoff for the upper limit of the mild range.
Okay. All right, but that's like not at all what the range is for MoCA, right?
No,
Yeah,
not at all.
If I were to think of like a similar range for MoCA, it would be more like 18 to 24.
Or 25, yeah.
Yeah, 16 to 25, right? Okay, so I'm just sort of calling out that strikes me as like really weird looking. Okay, thanks.
Yeah, and that just may be an inaccurate equivalency. So if that is the case, I definitely
no worries.
trust your opinions.
Okay, no.
And also, it may be common knowledge, it may not, but a lot of these study protocols, strangely enough, they actually go on MMSE score, whereas clinically the MoCA is often more commonly administered. So that equivalency calculation actually happens a lot. At least in my experience, and I realize I've primarily been working in a specialty clinic that does this a lot, and not everyone will do this a lot, but mostly MoCAs in the clinic and mostly MMSEs in study protocols. Okay, and I think that's most of the information for this slide. We're going to move on, just keeping time in mind, to the next study, which involves transcranial magnetic stimulation. Dr. Rosenblum is also one of the PIs on this study, along with Andreas Stocko, who's faculty in the School of, Psychology at UW. And this is indicated for individuals with mild stage cognitive impairment or mild Alzheimer's dementia. And it is involving transcranial magnetic stimulation. Notably, one of the things that I find unique about this study is that everyone who enters the study will receive the study intervention at some point or other, that will receive TMS. That said, everyone is also going to receive a sham at some point, and they basically do the sham by sitting you down in the TMS chair and putting the device on your head, and then they just block the device from block the coil, essentially. So it feels and looks the same as when you're getting TMS, arguably, but everyone receives the study intervention at some point, in addition to placebo. This one, I will also note that it is only currently open to patients who are involved with a memory and brain wellness clinic, who've been characterized through that clinic, or who are involved at the University of Washington ADRC. So it would be a two-step process to getting screened for this study: get involved at the memory brain wellness clinic or the ADRC, and then become eligible for this study. So this study, of course, involves TMS and is targeting the 8V region within the lateral frontal cortex, according to the protocol, which has been implicated in Alzheimer's disease-related cognitive decline. It is extremely time intensive, even though it is only 12 weeks total, relatively short for a clinical trial time length. It's very time intensive during those 12 weeks. It's 5 consecutive days of 10 daily intermittent theta burst stimulation sessions. So it is 5 days on, and then 5 to 7 hours per day, 5 days on, and then a brief washout period, and then 5 days on, 5 to 7 hours a day. First session being sham or intervention, second being the opposite. The aim of this study is to reduce an adaptive memory test tool's speed of forgetting. It's an experimental measure that was developed by Dr. Stocco and colleagues to help test pre and post treatment outcomes and speed of forgetting. So it's an 8-minute memory game that patients take before and after the test, and they're trying to see if the person is forgetting things faster or at the same rate or slower. An experimental test that they're developing. So they do these TMS sessions. They also have memory games interspersed. There's also some MRI imaging that happens. It's functional MRI imaging, 3 Tesla scanner, pre and post treatment. So of course, any contraindication to MRI machines like claustrophobia or having the implanted cardiac defibrillator would prevent people from participating. And let's see here. So far, the side effects that have been observed with TMS have been pretty minor. Headache, neck aches, muscle twitches, pain at the stimulation site. But that's another upside to this study, is just that the risks are relatively lower than some of the other studies. And it's relatively low barrier and non-invasive. Some considerations, of course, time. It takes a lot of time, even in that shorter time window. It's very intensive time. And the study actually does have limited funds, so it isn't really able to accommodate hotel stays and reimbursement for travel. I think it does offer about $50 upon study completion, but the main thing going for it there is that people are guaranteed to receive the study intervention rather than not knowing if they're getting a placebo. So they know for sure they get the TMS. And then as far as sharing of results go, this study only shares the results of the speed of forgetting task with participants after each round of stimulation. And this is done through verbal or written disclosure by a PI or a coordinator. So they talk about that 8-minute brain game and what it means. And because it's experimental, it has its limitations. It's not a replacement for anything clinical. Another study I'll mention is this just started up. It is Cogit 2. PI is Angela Hansen. Site PI is Angela Hansen. The primary site is Columbia University. So it is multi-site, and it is testing it is testing crossword puzzles and health education as a potential intervention to improve performance of everyday functional abilities in patients experiencing mild cognitive impairment. And I actually say subjective cognitive concerns and mild cognitive impairment, with the caveat that this study requires a MoCA score, unusually MoCA instead of MMSE, a MoCA score greater than or equal to 20 out of 30. And it also specifically says in the protocol, subjective cognitive impairment or MCI. So just calling it MCI for simplicity's sake here. So it's looking for folks in that age range of 55 to 89, which is pretty inclusive. 89 is definitely on the upper end. And there are 3 different arms of this study. And the way it's designed is it's looking for, the first arm involves participants taking crossword puzzles at a high frequency, completing crossword puzzles at a high frequency. The second arm involves completing crossword puzzles at a lower frequency. And then the third arm involves participants having health education. So if they're assigned to the crossword puzzles, the patients are using a web-based platform to complete puzzles at home, exercise the brain. And if they're assigned to the health education arm, they're reading assigned chapters from a health book. And we're trying to see, and of course, they're completing biomarker testing, blood draws to assess genetic factors and store plasma. They're doing MRI scans pre and post to learn about activity. They're doing neuropsychological testing to test memory, attention, language, and other cognitive abilities, all the while trying to see if any of these interventions have protective benefits. The study does involve a study partner. Actually, every single study we've mentioned so far involves and requires a study partner. That's very common in this line of research and can be a limiting factor. And this study does a fabulous job, in my opinion, of returning results. It's rare to see this much return of results, in my opinion. But patients are provided with an interpretation or local read of their MRI at the beginning and end of the study, as well as summary information about their memory testing. They're still deciding if this will be verbal or written, but a lot of good information. Participants are also compensated for being in this study. I think it's up to $360 for full study participation, and prorated based on what they complete. And at this time, there's no hotel stay compensation or travel reimbursement for the 6 clinic visits. Some of it's done remotely, of course. And contact information at the bottom highlighted as with all study slides here. I will quickly note, make a shout out to observational research. I know the focus here is more interventional, but we have a lot of observational research happening at our center as well that is equally important, some may say. It just does things differently. And some reasons why people may be motivated to participate in observational research in ADRD research is it can really help us better understand disease and develop new diagnostics like biomarkers, and it can help us identify new ways to prevent disease and potential risk factors. And it can also ensure that the understanding of the disease is equal across all demographics, and hopefully inform treatments that benefit everybody and not just a select few. This is just a list of some of the different observational, arguably observational, but some are actually interventional / observational studies at our center right now. It is not a comprehensive list, but it's to demonstrate that we have studies falling in many of these different categories, serving, studying conditions, including Alzheimer's, dementia with Lewy bodies, some that involve wearables, like the technology for early dementia diagnosis study, which is a wearable headband happening at the VA for monitoring it while people sleep, the lipid MRI study, which we'll touch on briefly, and also the UW clinical core study, which we will touch on briefly. There's also research happening for caregivers, like the Impact AD study, which we won't get into today, but there's more information about all of these studies on our website. The first study I'll highlight in this category of observational research is one of the pillar studies at our center, arguably the pillar study at our center, the UW-ADRC Clinical Core. And the PI is Dr. Suman Jayadev, neurogeneticist at UW Medicine, the Memory and Brain Wellness Clinic elsewhere, and also one of our longtime site PIs. This is an NIA-funded multi-site longitudinal cohort study, which involves annual research visits that include testing, biomarkers, or cognitive testing, biomarkers, and neurological evaluations to observe people over time and see what we can learn. And it is a multi-site study, so there are a lot of sites participating, and the data are aggregated in a place where researchers can access them and contribute to scientific discovery. Our study is available in both English and Spanish. Those are the only two languages that are this study is able to be conducted in currently, and I will throw out the language thing because I mention it now. All of the studies I've mentioned so far conducted in English, but every site's going to be different. Every study is going to be different on what language capability they have. It just depends on what's been translated and what staffing they have available with which linguistic expertise. The hope is for this study to become available more broadly in other languages over time. This study is really looking to involve people with mild cognitive impairment, study that early stage disease. How can we help prevent? How can we study resilience? It's looking for people over 85 years old who are cognitively well. Again, resilience is of great interest in our little research center, and then people with familial AD variations or frontotemporal dementia specific disorders are being studied. And we also have a very huge focus on trying to enroll people who come from racial and ethnic underrepresented groups, as well as geographic underrepresented groups, specifically from rural locations. We're really trying to understand these groups better. They are vastly underrepresented in ADRD research, and there's been a lot of push to include more people so that the treatments serve more equitably. Return of results for this study. This study has minimal return of results with one major caveat, and that is if the study team notices a change that's significant from year to year. And this often will come up in cognitive testing scores. If there is a precipitous drop or change, or someone is observed to have very significant functional differences, then the research team will notify the patient. This is not a replacement for medical care. And this study actually is conducted very differently at different sites. Ours is unique in that this is strictly a research evaluation, but it can be a pathway to a referral to medical care if we notice something is up. And then the second highlight I will just throw out there, this study is coming to a close relatively soon. Dr. Hansen, again, is the PI, neurologist at Memory and Brain Wellness Clinic. Gerontologist. And this is called the lipid MRI study. This study is investigating brain blood flow changes after someone has had consumed a high-fat drink. They get to drink heavy cream and then take brain images of the person before and after consuming this high-fat drink. So all subjects are receiving 2 MRI scans in one day. It is an acute meal study. It is not long-term, which can be construed as a limitation, but it's also a strength in its own ways. Each scan takes about 15 minutes. The age range is listed. The visits are about 3.5 to 5 hours long. And the primary exclusions are up here. One of the big things is just that this involves brain imaging. So, and also it may exclude folks who are taking common diabetes medications. This study is another one that does a wonderful job of providing results. It provides test scores and interpretations of the Montreal Cognitive Assessment, GAD-7 anxiety screen, the PHQ-9 depression screen, oral glucose tolerance test, diabetes screen, among others. And these results are given in writing as well and may also be discussed verbally with the PI and study team. So a lot of good data sharing with participants through this study. Okay, I realize we're coming up on time here soon, but how can people participate in research? You may be wondering, how do we connect patients with potential research? First off, everyone in the community, including patients of yours, they may contact these study teams directly if there's one they're very interested in. But they can also choose to take a more comprehensive, arguably roundabout path. And that is, they can join our research registry. Currently, that registry involves an informed consent process because it involves private health information sharing and access to patient medical records that people don't always understand upfront what that entails. So we have an informed consent process to walk through what that means when people are agreeing upfront to share their medical records with researchers. This is the breakdown of the basic steps. So they can so again, people can contact us directly, either by emailing us or calling our research line, which is actually outlined in step 2. Or they can contact a specific study. And usually it used to be within 2 weeks, but it'll likely be closer to within a month, just due to volume and staff changes. Participants, community members who contact our center are followed up with, usually via phone or email, and walked through our different studies and asked basic screening type questions to determine eligibility. If there, again, I always encourage people, if there's a specific study they really want to be screened for, and the rest they can wait on or pass on, then I just say contact the study directly and go to our website, because we list all of our studies on our website. That said, if they want to be contacted by studies that are happening in the future, then it may be worth going through this process of getting onto our registry. And joining our research registry, again, because of that informed consent process, it does mean getting in touch with our center. It does mean talking to a human, for better or for worse. And, that format is subject to change in the future, depending on what changes are made. But currently it's by contacting our center, emailing our main line, or calling our EDRC research line, which is actually kind of a brand new phone line we developed just for these types of inquiries. And that is usually manned by research staff. I think the proposal is for a rotating schedule of research staff, although it may end up being a designated person who's trained to walk through screening questions and help place referrals for patients. And by that, I don't mean in an official sense. I mean to help determine why they're calling and what would be most helpful information to provide. We do get calls at our center that are not research related, but people may think they are. And that's why I also put down here contact information for the Memory and Brain Wellness Clinic. Sometimes people contact our center thinking they can also set up an appointment with a clinician or a medical provider at the Memory and Brain Wellness Clinic. That is actually separate. But we are more than happy to help refer people if they end up at our door. I will also mention, a lot of our content initially began only available in English, and we do have a significant shift to, fortunately, being able to provide a lot of this information also in Spanish. And there's a Spanish language newsletter, as well as a newsletter that we publish specifically having to do with community engagement in a research context at the ADRC. And we're also involved with the newsletter that the Memory and Brain Wellness Clinic puts out together. So it's kind of a joint effort there. And those have wonderful updates and sometimes research specific updates. So we always recommend people who are interested in receiving those types of updates sign up online to be on our newsletter, which is available through our website, uwedrc.org. And without further ado, I want to thank you all for your patience and for listening, and open it up to questions.
Teresa, thank you so much for a very thorough and detailed overview of our clinical trials offerings. And you're starting to mention some of the issues that intersect between clinical care and research. I'm curious, we've got some time for questions or clinically oriented discussion.
Yeah, would it be helpful to hear from, I'm equally curious to hear what comes up among providers, but I'm more than happy to kind of talk about the conversations I have with participants and how we broach that question. Would that be helpful to start?
Well, let's see what our community has for questions first.
Sounds good.
Sylvia.
Yes, hi. That's very helpful. My main questions are there still limitations for people who are enrolled in ADRC-based studies? So not clinical trials, just the observational studies. Are you guys still doing PET scans, and do you release the results? Is my main question.
Some of the ADRC studies that are not clinical trials, are they doing these types of tests, and do we release the results? Is that right?
Yeah.
Yeah, that's a great question, and does depend on the specific study. And we had a list back a couple slides back. I'm gonna hold this slide up for a bit, but I'm thinking of specific examples because the answer is yes. There have been studies, and there are studies that do their own testing, and that have released results. But it's also been a sticking point. There are definitely studies that they may conduct a brain scan, but they're limited in how they can share those results, if at all. The lipid MRI study, for example, I'm pretty sure that's one of the studies we just went over. They don't do PET scans, but they do MRI scans, and they're able to share pretty much everything with participants, which I would say is the exception to the norm. Our imaging and biomarker core, which is a sub-study of the clinical core, that parent study that we went over, they also do different types of brain imaging. They're actually trying to figure this out right now, how they want to disseminate results, because the sub-study involves different types of brain imaging, such as amyloid PET scans, tau PET scans, and how to share that information. I'm thinking of other clinical trials specifically that have done PET scans. I'm not thinking of observational studies right off the top of my head that have done PET scans and been able to share, but there have been clinical trials that are able to share at least the primary result, even if they can't share the physical images or a full report. A study PI can sometimes disclose the result, but it is very study specific.
Yeah, so Sylvia, I'm involved with the clinical core piece, and every once in a while there'll be somebody who has, either a PET scan or spinal fluid. But my recall there is that they've also usually been involved in some other study, not just the observational study. But Kimmy, you could correct me if I'm wrong there. We don't routinely do advanced biomarkers for our clinical core participants, I don't think.
Yeah, I'd agree. It's pretty much study specific, and then also not to get too much into the details, but since these are NIH funded trials, every 5 years there's a sort of a revamping, and so I think most trials across the board right now with renewals, there's a lot of attention being paid to this return of results. So I think appropriately there are changes going on, but there is always an encouragement. You work with the person who's in the study and their family, but to make that, if they would like the connection with the treating provider in the community, that's always a very important discussion. So, and we encourage that communication.
Yeah, I'm just thinking from the clinical, like purely clinical side, right? Sometimes it's really hard to know, what to do and what to tell them. We have blood biomarkers, which is great, but that cannot necessarily tell you if that biomarker change is necessarily related to their clinical presentation. And so from my perspective, I approach it as the more information I have, the better it is, generally, not always, but the better it is. And so sometimes I remember back when I was at Stanford, I remember there was this patient who was really young, and we were really concerned that he had early onset Alzheimer's disease. And we did the spinal tap, and, you know, the results were half and half. You know, the the amyloid tau index was not completely positive, was borderline. His amyloid was low. We had the tau PET, and he had tau in his hippocampus and the entorhinal cortex and part of the parietal lobes. And we were like, okay, now we're thinking in the right direction, because they were going crazy. His wife was about to leave him because she really was convinced that he was doing things on purpose. But we knew he wasn't. And so I think that, you know, that was just one example that kind of underlines how important it is. There's another older patient where, you know, PET scan did not show amyloid, but his tau was positive in the hippocampus. And so, you know, he had memory loss, but probably it was a hippocampal sclerosis as opposed to, you know, an Alzheimer's disease. And so you can kind of, obviously with the caveats of this is a research test and we don't really know all the way, but you can kind of shine the way that way, which otherwise, you know, they have them pay $5,000 for a PET scan here, and the radiologists don't see a whole lot of them for the amyloid. Let's not talk about the tau. So it would just be extremely useful.
There comments, questions, experiences with patients who have, you know, inquired about research or that you've referred to research?
This is Karen Hayes. I'd like to share the experience of being a care partner with my husband, who when we were under the care of Memory and Brain Wellness for about 5 years, we probably enrolled in 12 to 14 studies, because he's a healthcare provider, anesthesiologist, and I'm a nurse practitioner, and we of course believe in biomedical research. And I'll just say the experience overall was, we both really liked it. The extra attention was really appreciated. And people who do research, they tend to get to spend more time with you, and they're super focused. You know, my husband just felt like he got so much individual attention. They were really interested in him, super pleasant, offering snacks. And it just, the whole experience just felt like a big plus to, you know, the limited amount of clinical time you can get. And so as time went on, he didn't understand that he was doing it for research and stuff, but it gave us some place to go that was welcoming, you know, dementia friendly spaces. And I know you can't put that necessarily as a benefit of the study, but I'll just say we had a really positive experience with and we did experimental, we did observational, we did partner focus, you know, as couples, and some things just for me as the care partner, caregiver. And yeah, so and another benefit of that is, of course, I talk up the studies in my support groups, and my husband has now passed away, but I'm still in a bunch of dementia support groups, and by the researchers being so pleasant and so supportive and kind, that pays dividends in terms of me recruiting other people to join studies. And so just know that ripple effect happens, because people's attitude in research seems to be really positive and a magnet to attract people, as opposed to the, oh, am I guinea pig, or they're gonna hurt me in some way or something. I'd like to put a spin that it is really positive for us.
Glad that was your experience. Barack, I saw you come off mute also.
I was just gonna say that it's you know, just the experience of primary care is that primary care like barely has time to evaluate cognition and manage mild cognitive impairment or dementia at all. And so like definitely doesn't have any time to really get into complicated questions about research trials. And so it's really the you know, I think like the the little kind of brochure that we could hand out to a patient that just, if research comes up at all, it's like, oh my goodness, I've got a phone number for you to call, and here it is, really, I think the best kind of possible hook for getting engagement in the clinical space. I mean, I'm so impressed with I haven't seen the ADRC kind of portal entrance page in a while. It's like dramatically better than it was before. Like it's very, very kind of user friendly now, and so really appreciate all the work that must have gone into that redesign. And but I guess I would just like also just kind of share, what Dr. Russo was saying of it's very, very awkward for people to not have access to the sort of results of things that are sort of done on them, and I think that for the smaller subset of people who are excited to engage in research just for the pure altruism of it, then I think that makes some sense maybe. But, I think that's probably a pretty small subset of the potential people who could be participating in research who really they want to know kind of like, gee, what could be in it for me? And I think the potential for results from the research to have potentially positive impacts on their care is like a huge hook. And there I would also say, like, especially from the primary care perspective, that has to include like, kind of major investment on the part of the research team to really sort of take on some kind of like ownership of communicating to patients about what these results mean, and communicating to and also communicating to clinicians about what the results mean, because few primary care providers are going to be as knowledgeable as Dr. Russo in terms of figuring out how to talk to patients about a result. And so I think the future of research in this area, I hope, is more disclosure of results and more engagement by the research team in communicating what the results mean to patients and clinicians.
Yeah, agreed. Sylvia?
I can just, I'm not that, I don't know why I raised my hand, but just amplifying that thought. Not the most expert of people here in this group, but yeah, it's really important. I've had a lot of questions about research in my just clinical work, and the main downer is when you tell them, well, sometimes you go there and you don't get a result. And so what's in it from me is unfortunately something that a lot of people ask when you're like practically minded. And yes, if we want to, do real world research, potentially thinking about that could increase the numbers. But I know it's very complicated and it depends on the study. And some of it, you cannot even tell them the result if you're getting cells that then get turned into neurons and then become part of a bank of neurons. What result do you get from there? Nothing. But yeah, for the tau and amyloid PET scans, it would be awesome if we could get at least some sort of disclosure of some sort of indication. It would really be awesome. It would change a lot, at least from my nerdy perspective. I'll leave it there.
Well, that is a wonderful perspective to have. Yeah, and it will be interesting to see kind of what unfolds with this push of more transparency around results and communication. So stay tuned. Maybe we'll get an update here before too long. All right, I realize we are at time. Again, thank you, Teresa. I want to do a very quick sharing of our kind of upcoming didactics, just to give you a sense of what's happening next. We have our very own Dr. Pattison talking about feeding in advanced dementia later this month, and see our other topics up through March. We only have another, I think, 1 or 2 sessions for the rest of the year that we need to nail down. Then we'll share the rest of our agenda for the year. So that's that. And again, you'll get a 1-minute post-session survey. I think Sammy just put in the chat the reminder about CME if you're a UW person. And thank you all for taking the time. We will be happy to send out some resources, including the slide deck with all the wonderful information about the ARC for you and your patients and families. So we'll see you next time. Thank you.
Right.